Dear colleagues, it is my pleasure to share in this prestigious congress, and my talk today will be about endoscopic ultrasound assessment of liver segments and its clinical applications and the recent advances in this field. My agenda today will be introduction, short introduction, segmental liver anatomy, linear EUS examination of the liver, and the clinical implications of segmental liver anatomy. EUS allows for the accurate evaluation of liver anatomy and the related pathologies and tissue biopsy of any focal lesions. The evolution of EUS-guided intervention techniques such as hepatogastroscopy, portal pressure gradient measurement, and ablation of tumors has attributed to the increasing importance of understanding the hepatic segmental anatomy during EUS examination. This is a simple diagrams describing the liver anatomy. This is the IVC, and this is the middle hepatic vein dividing the liver into its left and right lobes, and the left hepatic vein dividing segment 2 from segment 4 at its proximal part, and segment 2 from segment 3 at its distal part. And this is the right hepatic vein dividing the right lobe of the liver into medial segment, including segment 8 above and segment 5 below, and the lateral segment of the right lobe dividing segment 7 up and segment 6 below. This is the simple liver anatomy. But can we visualize all these segments during endoscopic ultrasound examination? Yes, in most cases. In 2021, we published a review article in the Endoscopic Ultrasound Journal trying to put a plan for examination of the liver to see all segments. And we should examine the liver from the stomach to see the left lobe and part of the right lobe. And we should examine also from the duodenum to see the whole right lobe of the liver. Let us start with examination from the stomach. We locate the echo endoscope just below the cardia, about 40 to 42 centimeters from the dental arch, from the incisors. And here our landmark will be the intrahepatic portion of IVC. Sometimes we find the descending abdominal aorta, its upper part. If we find it, then we do anti-clockwise rotation to go to our landmark to start with, which is the intrahepatic portion of the inferior vena cava. And this is the right hepatic vein. Why this is the right hepatic vein? Because its diameter at insertion with the IVC is the widest, is wide, with gradual decreasing in the diameter, with gradual sloping of its diameter when it goes deep in the liver. These two structures, inferior vena cava and the right hepatic vein, confine 3 segments in between. Segment 1, which is the caudate lobe in between the echo endoscope and the IVC, and segment 8 in between these two structures, and part of segment 7 deeper to the right hepatic vein. When we do counterclockwise rotation, we can find the middle hepatic vein. Why this is the middle hepatic vein? Because it has homogeneous diameter all through its course. And here also we can find another important structure, which is the fibrous ligament of ligamentum venosum, communicating the IVC to the left portal vein. These two structures confine 3 segments of the liver. Segment 1 is also the caudate lobe, and segment 4A in between the ligamentum venosum and the middle hepatic vein, and segment 8 deeper to the middle hepatic vein. We keep counterclockwise rotation to find the left hepatic vein, and segment 2 above and segment 3 below. To complete examination from the liver, we go back to the landmark of ligamentum venosum and the middle hepatic vein. Yes, ligamentum venosum and the middle hepatic vein. Then we push the echo endoscope inside the patient gradually. And here we can find the umbilical portion of the left portal vein with its fish eye appearance. This is the fish eye appearance of the umbilical portion of the left portal vein. Here we can see, by pushing the echo endoscope a little bit, we can see another ligament, which is the ligamentum teres to the left side of the screen. So this is the left portal, ligamentum venosum to the right side of the screen, and ligamentum teres to the left side of the screen. Here we can see segment 3 above, which is the best segment for hepatogastroscopy, and segment 4B is a large segment behind or deeper to the ligamentum teres and the umbilical portion of the left portal vein. So this is a diagram of this view. Ligamentum teres, umbilical portion of left portal vein, segment 3 and segment 4B below. Then we finished examination from the stomach. We go to the duodenum. We push the echo endoscope through the duodenal bulb and pushing it gradually again in the superior duodenal angle, which is angle just after the bulb of the duodenum. Pushing it gently, then the echo endoscope will acquire a long J-shape position, and here the scope is looking to the liver from below. Here we can see the main portal vein formed by the splenic vein and the superior mesenteric vein. Here we can keep counterclockwise rotation, but very slow and very gentle counterclockwise rotation to avoid complication. And a little bit downward. By this, we can follow the portal vein, the main portal vein, as it is going inside the liver. Here, inside the liver, it will divide into left branch and right branch. Here, this is the right branch of the portal vein. Now, going inside the liver, this is the right branch of the portal vein. Just minimal counterclockwise rotation, more and more counterclockwise rotation. And here the right branch of the portal vein will divide into its two main branches, right anterior branch and right posterior branch. The right anterior will separate segment 5 from segment 8. Segment 8 is above, and this is the diaphragm. And this is segment 8 superior, segment 5 inferior, as we are now looking to the liver from below. And here, this is the right posterior separating segment 6 inferior and segment 7 superior. So we can see the four segments of the right lobe of the liver during duodenal examination, but we must be careful to avoid any complication as perforation. When we go to the second part of the duodenum and clockwise rotation opposite to the papilla, then we can see the right kidney, and the segment of the liver at the level of the right kidney is segment 6. Then what is the clinical implication of this examination of the liver? It has diagnostic and therapeutic implications. Diagnostic, the most important is detection and characterization of focal lesions if it is small. Here, when we find a focal lesion of the liver, we can use all our facilities or our weapons, which is strain and shear wave elastography, contrast-enhanced endoscopic ultrasonography, and the gold standard for diagnosis of hepatic focal lesions is the FNA-FNB with accuracy up to 96%. Of course, there are many therapeutic implications. We all know EUS-guided biliary drainage, EUS-guided liver tumor ablation, EUS-guided cyst ablation, EUS-guided liver abscess drainage, EUS-guided measurement of portal pressure gradient, EUS-guided liver biopsy of diffuse liver pathology. Let us talk about some of the very important points. Let us start with the role of EUS in detecting occult liver metastasis not seen by CT or MRI. We all admit that multiple detector CT and dynamic MRI are the most widely available and acceptable non-invasive modalities for detection of liver metastasis. However, they have a limited ability to detect hepatic lesions smaller than 1 centimeter. And of course, the detection of an occult liver metastasis could have a major impact on staging of malignancy and changing the management plan. For hepatic focal lesions more than 2 centimeters, the accuracy of CT and dynamic MRI is high, more than 90%. But if the tumor is from 1 to 2 centimeters, the accuracy decreases to 71% and 65%. For tumors smaller than 1 centimeter, the accuracy decreases markedly to 38% and 26%. In Cairo University, in Qasr Aini Hospital, we conducted a prospective study over 5 years and included 730 patients with primary malignant tumors. Most of them are pancreatic, more than 500, but there were gastric tumors, cholangiocarcinoma proximal and distal, papillary, adenocarcinoma, lymphoma, and so on. In these patients, we examined the liver thoroughly to detect any hepatic focal lesions. 124 patients, about 17% of the patients, finally proved to have liver metastasis. 61% of them, of these metastases, were seen by endoscopic ultrasound and also well seen by CT and MRI, while 42 patients, about 34% of the patients, were missed by CT or MRI and seen by endoscopic ultrasound, while only 6 patients were missed by endoscopic ultrasound and they were seen by CT or MRI. For the 42 patients with metastasis who were missed by CT or MRI, their median of transverse longitudinal diameter was 12 by 15, rather small lesions, and 15 metastatic masses were smaller than 10 millimeter. All of these lesions were seen by endoscopic ultrasound and proved malignant by EUS FNA. For the 6 patients with metastasis missed by EUS, all these lesions were located in the right lobe of the liver, segment 5, 6, 7, and 8. And their median diameter was not small. It was about 16 by 20 millimeters. So what we'd like to say in this, in our study, is that CT and MRI can be easily miss small hepatic focal lesions, especially those smaller than 1 centimeter, while EUS can miss tumors in the right lobe of the liver, because examination of the right lobe of the liver by EUS is rather a little bit more difficult than the stomach, because the duodenum is a confined space, small space, and we should move very carefully to avoid any complication, while examining of the stomach is very easy. The stomach is capacious and we can move with more ease than the duodenum. And this study was published in 2021 in the Endoscopic Ultrasound Journal. This is one of our patients with pancreatic body adenocarcinoma. CT was free, liver was free, and during endoscopic ultrasound examination, we can find this small lesion, very small. It was about 4 millimeter by 4 millimeter in segment 4B of the liver. And here, when we find this lesion, we apply elastography, strain elastography. It's a very nice technique, especially in the liver, because we compare hard tissue, hard malignant tissue, metastasis, comparing it with very soft gelatinous liver. So the difference is high. So here this is colored by blue very nicely, while the soft tissue of the liver colored by green. So it is mostly malignant, and EUS FNB was done and proved liver metastasis. And here we can easily do FNA, FNB. Actually, it is very easy in the liver because the liver is very near to the echo endoscope. No intervening structures in most cases. So we can do it safely and easily, despite it is near to important structure like the diaphragm or the left atrium or the right atrium. But we can do here very nicely because the stomach is capacious. We can move very nicely, can locate the endoscope very nicely, and the liver is very near to the echo endoscope. And most of the articles in the literature agree with us that the diagnostic adequacy of EUS-FNA of hepatic focal lesions is very high. It is 100%, 95, 94, 94. So it is, the accuracy is very high in obtaining enough tissue. EUS can also be used in obtaining biopsy from diffuse liver pathology, not only from focal lesions, but from diffuse liver pathology. And now this is the trend, is to do it by endoscopic ultrasound, despite expensive. The systematic review showed a total of 9 study arms with 437 patients and proved that the diagnostic rate was about 93%, and the adverse event is rather small, about 2.3%, and the bleeding is about 1 to 2%, subcapsular hematoma less than 1%, abdominal pain requiring admission less than 1%, bile leak in only one reported case, and so on. This is the biopsy. It is activation. Go to the liver for half centimeter and then one push to obtain this very nice core, and it is convenient to the histopathologists. So liver biopsy, EUS guided liver biopsy is comparable but much safer than percutaneous or transjugular route. It is done by FNB needles, not by FNA, better by 19G needle, better from both lobes of the liver, and 2 activation better than 1. Let us go to another facility of endoscopic ultrasound, which is elastography. There are many types of elastography. 2 of them can be used during EUS examination, which is strain or real-time elastography, and shear wave. This is recently introduced in this year or in 2023 or 2024. Shear wave elastography, and there are another techniques, another types used by percutaneous sonography, which is transient elastography, and acoustic radiation force imaging. Let us talk about the real-time elastography, strain elastography, or we are all know because it is available since many years ago. Elastography is a technique that uses ultrasound to provide an estimation of tissue stiffness by measuring the degree of distortion of the tissue under the application of an external force. Here, the external force is the pulsation of major vessels, nearby major vessels. Malignant tissue force is harder than benign tissue. This degree of strain, different degree of strain, displayed in a color scale that ranges from red and green for soft component with greatest elastic strain to blue for hard tissue with no strain. There are 4 scores. Score 1, red-green color for the whole mass. This is soft mass. Score 2, red-green for a large part, more than 50% of the mass. And the stage 3, of course, more dangerous, blue color for a large part of the mass, more than 50%. And the most dangerous score is score 4, which is blue color in the whole mass, like these masses. Elasticity score 4 is highly predictive of malignancy. Sensitivity is about 92%, and sensitivity is about 80%. This is Juvenile Italian 2008. Now, a newly introduced type of elastography during EUS examination is the shear wave quantification. Shear wave quantification provides an absolute value of tissue stiffness with a region of interest. Yes. Quantitative tissue assessment was calculated by the propagation velocity of shear wave generated from a pulse wave. The region of interest is 30 to 40 degrees. It should be less than centimeter in depth. Avoid duct and vessels. It should be concentrated on liver tissue. Avoid big wheel up, and 5 to 10 consecutive measures should be done. In 2022, Shaw et al. Studied the EUS guided by lobar liver and spleen shear wave elastography and its association with hepatic fibrosis score. They found that the negative predictive value was 80% and the positive predictive value was 93% for predicting stage 3 and 4 liver fibrosis when endoscopic ultrasound shear wave elastogram of the liver lobe is more than 15 kilopascal and the spleen is more than 26.3 kilopascal. Here, the gold standard in this study was liver biopsy. So, concluded that EUS shear wave quantification has advantages over transient elastography percutaneously done by sonography in obese patients and patients with steatosis. EUS SWQ correlates well with liver histology. It is safe and reliable diagnostic test for assessing liver fibrosis with accuracy comparable to vibration-controlled transient elastography. Endoscopic ultrasound shear wave can be an alternative diagnostic tool for diagnosing chronic pancreatitis and predicting the presence of endocrine dysfunction, but this needs further research. And its role in lymph nodes, adrenal glands, and submucosal lesions needs further research. This is the last point of advances I'd like to discuss with you, which is EUS-guided measurement of water pressure gradient. The portal pressure gradient is the difference between the inferior vena cava and hepatic vein pressure and the portal venous pressure. It is normally 1 to 5 millimeter mercury. When it is more than 6, then there is portal hypertension. If it is more than 10, then there will be varices. If it is more than 12, then there may be variceal bleeding and ascites. Severity and portal hypertension more than 16 millimeter mercury is associated with increased risk of death, and the elimination of portal hypertension or decreased by more than 20% prevents variceal bleeding. Portal pressure gradient has many advantages over hepatic venous pressure gradient because it is a direct assessment of portal pressure, and it can determine pre-sinusoidal causes of portal hypertension and no major complications in contrast to hepatic venous pressure gradient, which is more invasive, more risk of bleeding, AV fistula, and bile leakage. And the technical success of portal pressure gradient measurement is 90 to 100%. The technique is to target the middle hepatic vein. Is first identified as we described in segmental liver anatomy. So segmental liver anatomy is very important to locate the middle hepatic vein just below the cardiac. And punctured by 25G FNE needle in the subcardial transgastric approach. And then the umbilical portion of the left portal vein fisheye appearance, as we previously mentioned, is then identified and punctured by 25G FA needle using also transgastric approach. The technique is 1 to 2 millimeter of heparinized saline is flushed through the primed FNA needle before each reading, and the reading is recorded after 30 to 60 seconds of pressure stabilization, 3 readings taken, and as I mentioned, the portal pressure before, the portal pressure gradient is the mean portal pressure minus the mean hepatic venous pressure. This is my last slide. It is a very nice study in 2024 by Akash et al. Who studied the utility of endoscopic ultrasound in Budd-Chiari syndrome, a multi-center, a multi-observer prospective cohort study on 50 patients. They mentioned that there is good agreement among endosonographers for diagnosing right hepatic vein and left hepatic vein lesions like thrombosis, moderate agreement of middle hepatic vein lesions. EUS, they concluded that EUS is a safe and accurate diagnostic tool for Budd-Chiari syndrome. It can provide accurate mapping of hepatic veins and intrahepatic collaterals and the IVC. So my take-home messages are: liver segments are examined from the stomach and the duodenum, and in each location, try to identify the landmark of each anatomical region. Thorough and meticulous examination of all liver segments is mandatory, especially in staging of pancreatic, GI, and lung malignant lesions to detect occult liver metastasis not seen by CT or MRI. And studying segmental liver anatomy is important for many interventional techniques as EUS-guided hepatogastrostomy, EUS-guided liver biopsy, and EUS-guided portal pressure gradient measurements. And thanks for your attention.